Hey peeps. Today we'll be talking a little bit about gestational trophoblastic disease. I plan on this being a series or at least a two-part lecture. First we'll talk about GTD and then we can talk about GTN. I will say that I'm not the expert in GTD because typically patients come to gyne-onc diagnosed with GTN. However, I do think it is an important introduction to talking about GTN, so let's do it. So some things that we'll go over in this series, GTD versus GTN, and how can we explain this to patients, and then diagnosis, management of all the things. Okay, so here are the key references used for these lectures. I will frequently go back to the NCCN guidelines during these lectures, and then the Lorraine papers are excellent. And then we have this clinical expert series from 2021, which is a really nice overview. So if you want to learn more, go ahead and download those papers. Okay, so GTD, a spectrum of disease processes originating from the placenta. These can be benign or malignant. So the benign moles, a complete or a partial mole, they have malignant potential. And then the malignant, otherwise known as GTN, you have your invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. Those last two we won't really go into any detail here, but we can always talk about them at a later date if you would like to. And so we know that the benign forms can eventually transition into a malignancy. And that leads us nicely into this next slide. So how do you actually explain this to your patient or even explain this to yourself? It is a very difficult situation for the patient. A lot of the times they're trying to get pregnant and then find out that they have this pre-invasive disease. So it's very important to have the correct language and be able to counsel our patients appropriately. So how do you explain it? So you can say this is a rare tumor that arises after a sperm and egg join, and they don't develop into a fetus. Instead, they create abnormal cells which develop a tumor inside of the uterus. You can say this is an error in normal fertilization that leads to some abnormal production of placental cells. You want to emphasize that when patients are diagnosed with GTD, this is not cancerous, but it has the potential to develop into a cancer, and so we need to monitor closely. And I think that's an important thing in this population. It's very important that you continue to follow up with us because this can lead to a cancer. And I think one of the most important things that we can tell people is that the vast majority of patients go on to have healthy pregnancies in the future. So explaining the definition and the pathophys a little bit, and then giving the importance of why we need our patients to follow up, and then also giving them some hope and some support at the end to say that, the vast majority of patients go on to have a healthy pregnancy. Okay, so I think a lot of people commonly know the presentation of molar pregnancies. The vast majority of patients will present with vaginal bleeding and a positive pregnancy test. And here you can see a nice picture of a complete molar pregnancy. You can usually diagnose this by ultrasound, and then partial mole is usually diagnosed after you do a DNC for a missed AB. And as far as risk factors go for molar pregnancy, the two established risk factors are extremes of age and prior molar pregnancy. So women who are greater than 35 or women who are less than 21 have about a two times higher risk, 1.9, than women between 21 and 35. And then women greater than 40 actually have a 7.5 times higher risk. And then the risk of a repeat molar pregnancy after one mole is about 1%, and that's 10 to 20 times greater the risk than the general population. A history of a spontaneous abortion has about a 2 to 3 times increased risk of a molar pregnancy. And then there are some environmental factors that have been studied in the past that we can't really hang our hats on, but beta carotene has an inverse relationship with molar pregnancy. Animal dietary intake has an increased risk or has been associated with the evidence of a molar pregnancy. And then prior ovulation induction increases the risk of multiple gestation, which has been observed to contain a normal fetus and then a complete mole. So questionable on those, but I would say the two most important ones are the extremes of age and prior molar pregnancy. Pathologic features of a partial mole. The partial moles have a triploid karyotype, usually 69XXY, and this results, as you can see from the picture, from dispermic fertilization of an otherwise apparently normal ovum. So it is an egg fertilized by two sperm, resulting in this triploid karyotype. For partial moles, you will typically see fetal parts present, and so you could think of the word parts with partial. You may only see focal villus edema and focal trophoblastic proliferation, and those are in comparison to a complete mole. And then on immunohistochemistry, you'll see P57 is positive, again, in comparison to a complete mole. Clinical presentation, like we said, vaginal bleeding, you'll oftentimes see with the positive pregnancy test. The partial moles will often be diagnosed as a missed abortion on ultrasound, and then after they look at it in pathology, it's diagnosed as a mole. Some of these other things are just kind of comparing it to a complete mole, but you'll usually see uterine size around dates or less than dates. You won't typically see theca lutein cysts, won't typically see any crazy medical comorbidities along with this. The quant is not typically extremely high. And as far as the incidence of postmolar GTN when we're counseling these women, it's less than 5%. So you can say somewhere around 5%. And then on to complete mole. So complete moles almost always have a chromosomal complement totally derived from the paternal genome. The 46XX karyotype is the most common, and usually these will arrive from an ovum without any maternal chromosomes and is fertilized by one sperm, which then duplicates its DNA, resulting in the 46XX androgenic karyotype. Another nice picture here. So when we're looking at this and comparing it back to the partial mole, fetal parts will be absent. You'll see diffuse villus edema. You'll see diffuse trophoblastic proliferation, and that P57 IHC will be negative. Clinical presentation, first trimester bleeding. You will see, we had that picture a couple slides back you can go to, abnormal ultrasound findings, absent fetal heart tones. You'll usually see size greater than dates, and you can see theca lutein cysts sometimes up to 25% of these patients. You can see these medical comorbidities, hyperemesis, preeclampsia, thyroid storm. They're rare, but they can definitely happen. And then you'll oftentimes see that the beta HCG is very high. And then when talking to these patients about the risk of postmolar GTN, I typically say 20%. So 15 to 20% is what we have here. So definitely need to be watching these patients very carefully once you manage and treat them, which we'll go over next. So management, you definitely, like always, want to get your H&P and then some labs. So you'll get a beta, which I'm assuming you already have. You definitely want to type in screen because you want blood to be available. CBC, comp, coags. You got your ultrasound. Get a chest x-ray beforehand to just be sure to rule out any METs before proceeding. And then proceed with your suction D&E. You want to have PIT available. You want to have all uterotonics available. And then other things, induction is not recommended. You want to be sure that you are at a facility that can handle a procedure like this that could have a high blood volume loss, as well as needs to go to the ICU afterwards. And then hysterectomy is an option for patients who don't want future fertility, or they're greater than 40 and don't have plans for future fertility. But these patients still need follow-up, and there's still a 3 to 5% risk of postmolar GTN. So immediately after evacuation, if the patient's Rh negative, you're going to want to give RhoGAM, send off the specimen for pathologic evaluation, and then if your patient came in unstable, you'll definitely want close monitoring for any sequelae. So if your patient came in with preeclampsia, monitor them a little bit extra long, especially for oxygen monitoring and any other sequelae after surgery. And then as far as contraceptions, OCPs are the preferred method. You can reassure the patient that this does not increase the incidence of postmolar GTN or alter any pattern of regression, but it does help when you're monitoring betas to know that the patient is not going to get pregnant in the short interval time period. Nexplanon is an option, and then there's limited data on IUD use, so I can't really comment on that. But OCPs are preferred. Okay, so our goal of monitoring the patient afterwards is just early identification of GTN. Most will occur within 6 months, so serial betas, you want to get one within 48 hours of your D&E, and then every 1 to 2 weeks until it's negative, 3 times in a row, and then monthly for 6 months. Follow up post-operatively 1 month for a pelvic exam, just to be sure that you don't see any vaginal mets and that everything's going fine, and then continue contraception. Management will be the same for partial and complete mole. So here are the NCCN guidelines. We went over these. They do include a workup, so if you're ever needing kind of a quick resource, head on over NCCN. You can make a free, I recommend that you make a free login and go on and check this out. So you did your initial workup because you were suspicious. You did your section D&C. Pathology came back with a complete or partial mole. They do recommend HCG every 1 to 2 weeks until normal, and then normal until 3, and then every 3 months or 6 months. So FIGO recommends confirming beta normalization with the second value and then discontinuing monitoring for partial moles, but to continue monthly monitoring for 6 months for complete moles. There are other resources that suggest shortening the surveillance for complete moles. I would follow NCCN guidelines. Okay, and our last slide, just, your patient is going to ask, is this going to happen again? And so, as we said, the highest risk factor, one of the established risk factors for a molar pregnancy is a prior mole. So there's about a 10 to 15% risk of recurrent mole, or an absolute risk of 1%. So I really like this chart here because the baseline risk of a molar pregnancy is 0.1%, a second mole 1 to 2%, and a third mole 15 to 20%. And so when these patients get pregnant, you definitely want to get a first trimester ultrasound, send their placenta to pathology once they deliver, and then get a beta at 6 weeks postpartum. You can reassure your patient, like we talked about, that most patients will have a subsequently normal pregnancy. And then even in patients who've received chemo for GTN, most will resume normal ovarian function and not have an increased risk of infertility. I do have a note down here that germline testing should be considered for patients who have more than 1 molar pregnancy. So that's it for this. We will go on to GTN on the next couple lectures. I hope you enjoyed.